Good morning. Here we are. A live suturing course like nobody else has ever done. And what are we covering? We're covering every suturing technique you could possibly need as a future surgeon. A junior surgeon, maybe you're an even advanced surgeon. But we're going to cover every suturing technique you can need. You're going to learn all my tricks from the last 10 years that I've picked up that I think you need to know from the beginning. We've got sutures here by a company called qeustions. Use them regularly, very, very good. And we've got a skin pad right here by my suture. You can get this from our website, product is tagged below. Comes with sutures, sharps pad, instruments, and if you get it from our website, you also get this upgraded needle holder. So we're covering every suture technique, skin pad, get it from our website, it's by my suture, comes with our needle holder, sharps pad, all your instruments, comes with a ton of sutures. And let's get started. So first thing we need to do is classify our sutures. You've got monofilament, braided, other braided things include silk, dissolvable, non-dissolvable. Preference depends on the situation. You can use whichever of these you would like. But the key is knowing what you want to do. So principles, dissolvable sutures in children, because they don't like having stitches removed. Monofilament, where you think there's a higher risk of infection, so you've debrided a wound. When you've got skin, so the really elderly or the really, really young, the dermis is really thin, the second layer. I prefer to use a braided suture because it has better grip, so less likely to rip out and cheese wire through. We need to start with our basics. Our basics is the interrupted. To do that, we have to be able to hold our instruments. Middle finger, ring finger. Middle finger's here, ring finger's here, thumb is here. So 2 fingers in the rings, middle finger's on the angle for support, index finger is for precision. Forceps are like this. One of the key things people do wrong when they're starting, when they're stressed, is they go into this position. So 2 things that are wrong here. The forceps should be on top of the finger. Your finger should be further down so you can apply gentle pressure between the teeth. If you hold it up here, you have to apply a lot more force to get those teeth closed. So if you just hold it down here, you have the mechanical advantage. In terms of the needle holder, don't let it go down your fingers. This is what happens when you're stressed. When you do that, you lose range of movement. Keep it in the pads of your fingers, and you can just gently lock and unlock the ratchet. If you look at the needle holders, they have this ratchet right here. You have to put down pressure on one, up pressure on the other to open it. So it doesn't require force, just gentle pressure. If you know how to drive a manual, I'm going to expose some of you here. If you know how to drive a manual, when you first learn to drive, you think you're in Fast and the Furious and you're a bit like, put that on the clutch and moving the stick really, really aggressively. And as you get more experience, you just realize you can just move it really gently. The ratchet is the same. It's just a gentle movement. The other way of holding the needle holder is the palmed grip. So your ulnar 3 fingers, little ring and middle, go on one side. They're going to push down. Your thenar eminence, these muscles here by your thumb, are going to push up and unlock it like that. So it works really well when you're using a bigger needle holder. This is just for skin, so it's a small tungsten carbide needle holder. So tungsten carbide, the gold means it's got better grip. And you can see that because it's got the kind of cross hatching at the teeth. So unlock it like that. Another way of palming it is like this. I tend to do that if I'm doing backhand. If your wrist rotates really nicely, then that's good for you. You don't have to keep your fingers in. My wrist doesn't really supinate or turn backwards too far. So to get more range of movement, I can twist the needle holder with the needle in it and start however I want. It's just an extension of your fingers. So this is the ideal position. Or like this. Let's throw an interrupted stitch. If you're getting value, do like the video, because our goal here is just to share as much knowledge with as many people as possible. And if you like it or leave a comment, it will spread. And it's free. So what we want to do is take out our needle holder. Take it out like this and pull the packet away. You're going to go in at 90 degrees and rotate. Palm your forceps. With one hand, pull the suture like this. And then rotate. 1, 2, grab the tip and tie. Notice that my fingers just went like this. I didn't move my whole body. So it's just like this. You've got a loop there, go in between it. So rather than wrapping it, just put your hand down. It will make the loop. Grab the tip and tie. It's a really gentle movement, and that's it. Slide down into one hand, everything into there, and then you can cut for yourself. How I hold my scissors: thumb, ring finger, middle finger on the angle, and then I can palm it if I'm going to keep cutting for myself, like so. Okay, so let's do that again. Let's look in a bit more detail. We're going deep. Interrupted suturing. 90 degrees is the angle of entry, so I'm not going in like this, I'm going in like this. 90 degrees. You don't need to pinch the skin, you need to go across at the same level. I can see this depth here, so I'm going to go across in the same level and rotate my wrist. Grab the forceps, the needle, palm your forceps with one hand, pull the suture, as I said, push forward, 1, 2, wrap it around the tip, don't wrap it around here, because often you get stuck in this groove here. Just wrap it around the tip, 1, 2, it's not this big movement, it's just a really fine movement to get the same result. You don't need a long tip when you're suturing skin, and it's just till the skin touches the skin. It's not over strangulated, it's going to get swollen. Don't squeeze it too hard. And wrap, and just alternate the position of the sutures, and use your finger to alternate the position of the thread. Like this. Monofilament, you need to do 4 knots. Braided, you can get away with just 3. If you're getting value, and you think other people will get value, just press like, because we just want this to go as far as possible, so as many people as possible can learn these skills. That was the interrupted suture. Now, we have a long wound, we'll just say it ends here, closing here to here. We're going to do a continuous suture. Why a continuous suture? Well, the wound isn't under any tension, the edges are reasonably well approximated. Could you just glue it? Yeah, you could, but I think if I stitched it, it will hold and the scar width will be a lot smaller. If the body part has distracting forces, so let's say muscles, and the patient is going to be running, playing, smiling, it's on that part of the body, it will pull the wound apart and the wound will take longer to heal. So rather than putting glue and letting it stretch open, you can stitch it to counteract those distracting forces. So we're going to start, if you're right-handed, you want to stitch towards yourself rather than away from yourself. I'm sitting here, so it doesn't really make much of a difference, but I'm going to start here because it seems like it's downhill. But it won't really make a difference. Let's start here. Because I'm right-handed, I think that will work better. What you don't want to be doing is stitching backhand. Finger tight, see how it's closed? Just that's the end point. You want the suture the knot to stay on one side of the wound, not in the middle. And then you're just going to cut one end of the suture, leave a centimetre or so, half a centimetre, and that's enough. And then here's where we learn the tricks for speed. So this is our impromptu suturing course, just to say thank you for being a follower, subscriber, and it will be posted on our YouTube, so subscribe if you want to watch it in full if you don't catch the full thing. So now I need to go over and over and over, but here are the tips for speed. Go across, I'm going to change my forceps to a finer one, and then rather than trying to grab it vertically between the 2 prongs, which isn't going to be that easy a feat, go across it horizontally and mount it straight away, like this. Go across it horizontally and mount it straight away. You'll notice that I'm not getting caught in my suture. The mistake to make would just be going on top. I'm on top of this suture thread. So if I pull this through and mount it straight away, I'll get caught in a knot. So now I'm going to waste time doing this and grabbing it. And so I've lost a couple of seconds. So always anticipate your next step. You just go straight across the wound, go across it horizontally, pull it through, mount it straight away. Push, grab it, mount it straight away. It's just about reducing maneuvers that waste time. So it's a really straightforward suture. Why would I do this rather than interrupted? Just because I don't have to keep cutting knots. It just seems to waste a lot of time. And when the patient has the sutures removed, if they're non-dissolvable, they just cut the ends here. So now pay attention to how we tie our knot for the continuous suture. If you're getting value, please press like so other people can see the feed and they'll also learn. 1, 2, that's a surgeon's knot. 2 revolutions on the needle holder. 1, 2 is a surgeon's knot. 1 revolution is a reef knot. It's kind of a bit loose, so I'm just going to pull the short one first to tighten it, and then the long one. That was a slip knot because I didn't alternate the position of the threads, and that's a surgeon's knot, a reef knot because I've alternated the position. Slip knot is when it goes back to where it came from. A reef knot is where it's alternating the long and the short end. Cut, and then you have a continuous suture. The next technique we're going to do, another simple, useful technique, is the horizontal mattress. The horizontal mattress is a really useful suture for everting a wound edge. Because often in trauma, so elective surgery, you make the incision, the edges are fairly evenly beveled. In trauma, usually the edges, because it's usually caused by blunt force trauma or a fall, the edges kind of curve in. So you often want to bend them out so that epidermis touches epidermis and dermis touches dermis. If you get dermis touching epidermis, it won't heal. If you get epidermis inside, little fragments, you'll get cysts. So, the horizontal mattress. The key to this is how to reverse your needle. I'm going to show you 2 techniques to reverse your needle. Grab it horizontally across the needle rather than vertically on the needle. Push your hand forward. That didn't work. Let me show you again. Because we're live, you see all the problems. And then push forward and it rotates. If you do it too slowly, it doesn't work. I'll just show you one more time. Go across and push forward. And it rotates the needle so you can mount it straight away. And then you can do the horizontal mattress, which is where you go adjacent rather than in line to your second bite. And then come out next to your first. I don't let the loop go all the way down because when I tie it, it will go all the way down. 1, 2, a surgeon's knot. It will close. And you see how it everts it just a bit more than that. That's what you want. This is the horizontal mattress. So it just gives you a little bit of wound edge eversion. If you got value out of how I turn the needle, press like. The other way to turn the needle is a way that I think is useful when your other hand is busy and you haven't got an assistant. So let's say you're stitching on the back of someone's arm, or you're holding something out of the way, you need to place the stitch. You only have one hand, you can't use your forceps. I know some people find it very hard to believe that would ever be the situation. It's happened to be plenty of times. So you reverse the needle, and we'll do it with a vertical mattress this time. So small gap, we want to invert it. We're going to do the other way of maneuvering the needle. So you go across, mount it straight away, pull your suture. I haven't turned it yet, so I unlock the ratchet and I push down on one side. That didn't work either, so I'll show you again. You have to do it with a bit of pace. And as we're live, you see the challenges of a non-pre-recorded technique. So we just go like this, and it rotates. I'll do it one more time. So you don't puncture the skin, you'll see it bleed if it does, and you do it somewhere it's really anesthetized in case you press a bit too hard when you're starting and you do puncture the skin. But it works perfectly well when your other hand is busy. Unlock the ratchet, and just rotate. Go in directly in front for the vertical mattress. So the horizontal is next to, adjacent. The vertical mattress is in front. And I use it for like punctate gaps that I want to invert. I think if you do a whole wound of vertical mattress, it will just take too long, in my humble opinion. Leave your short end no more than 2 centimeters. I tend to go about 1.5, 1, 2. It loosens. I'm going to let the short end come back to where it came from. Pull the short end only. It closes again. And then we do a reef knot where we alternate the position of the long and the short. And then we cut. But I prefer the horizontal mattress. Personally, if you get value out of this, press like so other people can see it. Leave a comment if you have any questions. The other and the third option for mattresses is the half buried. It's good for wounds like this. And how does it work? You go across like a horizontal mattress. I always advocate for going across your needle rather than trying to grab it vertically, because you're more likely to miss, less likely to miss. Mount it like you're going to do an intradermal suture. So you're going to go across the tip, just the tip, in an intradermal position of the skin, so just under the epidermis on top, so you can't see it on top, like so. And then go into the other corner like you would a horizontal mattress. The question you need to ask is, why would I do this rather than interrupt the sutures? Well, to close this kind of gap, you'd have to put one here, one here, one here. That's a lot of sutures in one small area. You're likely to get tip necrosis. So that's a lot of knots, a lot of tension in one area. So this is just one nice technique to, I think, reduce an unnecessary amount of sutures for a small gap. And then you can do whatever you want for the others. Sometimes less is more, and you can just do an interrupted. So, or you can do a horizontal. So we've done interrupted, continuous, horizontal, vertical, half buried. The next suture you need to learn is the subcuticular, or the intradermal suture. So we're going to do that, and we're going to do it here. So we're going to do the pull-out subcuticular first, and that's going to be one which we take out of the patient in like a week or less. So you start by going in outside the wound and entering inside the apex. This is another technique about speed. You need to take intradermal bites, so just under the epidermis. Make sure you capture the apex first, because it's often where you get the gaps. And you're going horizontally through the dermis. Mount it straight away, and make sure, I think you need to do the other apex. So for me personally, because my wrist is not that flexible, to do the side further away from me, I palm it like this, but I'm palming it. This is the second way of palming it. So I don't do this, I do it like this. So that way, to get the axis, my hand is coming vertically like this, but the needle holder is like that, and then the needle is at an angle. And that's just so I can get this. You'll say, why do you have to do all that? Can't you just keep your fingers in? If your wrist allows you to do that, then don't do this. My wrist does not allow me to do that. But it's about practicing, and simulation is about figuring out all the quirks and all the things you can and cannot do, and all the things you think are comfortable for you, so that when you do it in reality, you've covered all those things, and it's just about finesse and nuance. So small bites, horizontally across the dermis, mount it straight away, and you go in opposite where you came out. I'm going to put my scissors down because I'm not cutting anything. So we've been using this skin pad, this very skin pad. When you look at it, you can see it's been well used for the last 5 weeks. So it's pretty robust. You can see that we've used everything, every wound, several times, cut several sutures out. Did a course yesterday, and it still works pretty well. So it's high quality. I say if we used it twice a week, the whole pad, twice a week, lasts at least 6 months if you respect the skin, in particular when you're taking out sutures. So don't cut the pad, just cut the suture material itself. So this is a nice way of closing a wound without leaving stitches on the outside, except at the beginning and at the end. When would you use it? So a pull-out subcuticular is good for children. If you don't want to use dissolvable stitches because your risk of the inflammation, you'll get concerned the risk of inflammation will leave stitch marks. The pull-out subcuticular is good because you don't cut anything, you just unzip it. And then as you get to the apex, make sure you catch the apices. So you might have to go back on yourself a little bit. But it's just horizontal bites in the dermis, which is the same for the buried subcuticular. And then when you get to the very end, you capture the edge and then come out. Same way you started. Like this. And then you just make sure that your suture glides before you cut your tips, because when the patient comes back, if it's locked, it'll be a problem. So that's zipped really nicely. You keep it like this, put some steri strips on top, and then put some steri strips like this with the suture threads like that, crossing each other, and then in a week's time, you take it out. So I'm going to try and unzip this, and it shouldn't disgrace me, which is great. So the suture also has memory, protein more so than nylon, but it means that it stretches. So you see how I'm putting the suture through in skin, this will pull out a lot nicely, a lot easier, but in a skin pad, this good quality grip layers in it, it just takes a bit more effort, but that's okay, it's coming. We know because we're watching the short end. I'm gonna use my assistance. The other good thing about the skin pad is that you see how I'm pulling tension and the pad isn't moving, it just sticks onto the surface. If you buy another skin pad from other companies, the cheaper ones, they just fly everywhere. And you have to tape it down, it ruins the aesthetics. So you see how I'm unzipping it, unzipping it, unzipping it. People that have their eyelids done, blepharoplasties, this is often the suture you use. So that was the zip stitch, the pull-out subcuticular. To do the buried subcuticular, we're going to use a dissolvable suture. So for the pull-out, use a non-dissolvable. Proline typically, I think, works pretty well. Glides, monofilament, doesn't grip too significantly. For the buried subcuticular, if they've got thin skin, I use braided. If they've got thick skin, I use good skin, good dermis, I use monofilament. So when you have a needle in a packet, you can see it, you can just grab it there. So you can see this one's a bit different. What it's got is what you call a compound curve. So it's slightly different in terms of its position. So it's got a short hook. This is really good when you're stitching intraorally, because the angle means that you can really easily just turn like that and it hooks at these depths. This is not good for what I want to do. So we're going to use monocryl instead. And then we'll talk a bit about some other details that you can get from a suture packet. So you can see it's here. Mount it straight away. You need to anchor it. It's not under any tension, so I don't need any deep dermals here. Take a bite deep. And just tie it off so that the knot is deep and buried. I'm just using one hand rather than doing the whole tug of war thing. Go around twice, 1, 2. 1. And then this time, cut this suture flush. I'll zoom in even more so that you can see it in all the detail and all the errors that I may make, because that's what we're here for. So suturing live to show you all the techniques you need to know how to do. It's not about rushing, it's just about economy of movement and efficiency. So we're anchored here. Because the anchor point is there, so just reverse the needle without having to manual handle it. The anchor point is about here. I'm going to go back on myself intradermally. To make sure I capture the apex to reduce the risk of it having a gap at the end. Make sure you're in the intradermal tissue. Don't get caught in a loop. And I cut it out. So this happens in real life, so you just have to get used to it. So that's why I try and take a big bite at the start, but often means I have to go back on myself. Let's try that again. I cut my knot at the beginning, 1, 2, when I was cutting the short end. Happens. I'm gonna do a slip knot so it goes back down. Let's do a few more knots to make it a bit more secure because it's monofilament. And then we cut just above the short suture. So we're here. We're gonna go backwards. This is the buried subcuticular. You don't have to rush, just take your time and get it how you want it. And then we just go here. Try not to get your other suture, otherwise again you will cut the knot with the suture because it has a cutting face. And then we go. And then we continue as per the buried, the pull-out subcuticular or intradermal, opposite to where you came out. I've palmed it now because my wrist doesn't move. Small bites. And go in opposite where you came out. You want to make sure you get good excursion. So rather than going just on the edge like this, you want to make sure you get a good depth of bite. So if it was to come out, it would come out over here. But we're not going to do that. We're going to then rotate our wrist, push the skin back, and grab it here. I'm trying to mount it down here rather than taking it out and mounting it in the air because I think you lose more time, especially if you miss position it and have to manhandle it several times. And then I just want to come out here. Pull it along rather than backwards so that you don't rip it out, or cheese wire, as we say. And it's called cheese wiring because you cut cheese with wire if you're bougie like that. Pull down. The key to this one is you need to watch how we close at the end, yeah? It's the Aberdeen knot. It's really, really important to get that down, especially if you want to do general surgery, because it's one of the key knot types, especially when you're suturing the rectus sheath. You want to anchor that knot. So we're here. Take a big bite. Really, really get good purchase. Really important that it'll rip out. Don't hit any structures. Now we have a loop. We're going to do it this way. So let me zoom out. If you're getting value, like it so other people can learn. And that would be really, really helpful because we want to spread this information as far as possible. So 2 fingers, thumb, index. I'll zoom out even more. The needle is on this side. I'll leave it there so you can see it. you're putting the suture of the needle through the loop, which makes another loop. If you just put it, there's two ends here, top and bottom. Pull the bottom one, it makes the knot slide down, like that. Make the loop again, pull the suture through, and then pull the bottom one, makes the knot slide down. Now it's secured, keep doing it. I'm going to make it a bit shorter. Needle's still here. So this comes through. I know I need to pull the bottom one, so I don't need to make such of an exaggeration of the pulling it through. Needle's still here, so it's a monofilament, so 4 to 6, let's do 6. So that's 4, 5, and then on the 6th, we pull the whole thing through and the needle knot goes down. So we've got a little gap at the end, so there's two things we can do. We can, so one, take a bite deep inside and bury it. That will pull the knot through and down into the wound so it doesn't get visible. Cut flush on the skin. And then to cover this gap, you just get a small dissolvable suture like Rapide. So it's made out of Vicryl, it's very fast dissolving. And then you take a small bite here, because if you're using dissolvable sutures all the way, you may as well use a dissolvable suture for this little gap. You could do the same thing there, like a 5-0, 6-0 if it's skin, and then just 1, 2. To just complete the work. So that was the subcuticular. The last technique we can do on this Sunday morning live, we've done interrupted, continuous, horizontal mattress, vertical mattress, half buried mattress for these corners. We've done the pull-out subcuticular, the buried subcuticular, the Aberdeen knot. The only thing we haven't done is the deep dermal. So let's do that. So we've got a big wound like this. We've talked about how to turn the needle around. Big wound like this, it's under tension. I could start putting the deep dermals in, but I've got a monocryl. It's likely to cheese wire. So I want to take out some of the tension before I start. So I'm going to put in 2 locking mattress sutures. Oh yeah, there's more suture techniques that I haven't told you about. I've been keeping them to myself. Push, mount, go. So it's like a horizontal mattress. Go a bit broader. Pull through. Before the loop goes down though, put the needle through the loop. And then the suture thread will stay on top of the skin rather than going into the skin like that horizontal mattress. And this will just distribute the tension evenly across the 4 points of the mattress. And it will narrow the wound. So I know it's under tension, so if I let go of this, it probably will reopen. So to prevent it from doing that, I'm going to put my index finger of my left hand, go under the suture, keeping the tension across the cross of the suture. I'm going to make a cross over my finger, like this, and press the middle of the cross. Go under that loop of thread and pull the suture through whilst maintaining pressure on that cross. Do not release the tension. I've pulled it through the loop, and now I'm going to take that tension that's in between my fingers onto this suture up here. Pull up high, and if I was to let go, the wound still stays closed, so I've got the tension in the suture. Now pull the knot down, and it stays. And then we just finish off. This is a tension alleviating suture so that I can put in my deep dermals without having to sweat. And I've sweat enough, making sure that all my sutures work first time. But remember, when I did this twisting of the needle and my intradermal, I cut my sutures and didn't do it right the first time. So I think you see me sweat a little bit. Just a little though, not too much. But it's very much things that can happen in theatre, so you've also seen the solution to the problems. We'll do another one in the middle, big bite, because we're going to take this out once we put the deep dermals in. It's just to alleviate tension. Let's do it the other way to reverse the needle. So we're like this. It didn't go into the skin, it didn't leave a hole, it didn't make it bleed. Put it through the loop. and tie. 1, 2. And then we're here, finger underneath, make a cross over your finger, go under, pull the suture through, take the tension, and then slide it down. So now I'll put my deep dermals in between without any hard work. My continuous is alright because it still maintains closure. That's directly where it is, so it's pulling it open, but that's okay. When you finish with your needle, you're not going to use it again. Turn it into the body of the needle holder. So if anyone rubs their finger, they're not going to cut themselves. Even better, if you're not going to use it again, don't let it go into the jaws. If you're not going to use it again, put it in the jaws, and then it really is safe. And then you can pass it back to your theatre practitioner that's assisting you. And if you haven't got a theatre practitioner because you're by yourself in the emergency department, put it in somewhere safe. So now some deep dermals in the middle. You can see now this is practical, and I actually can do this without having to work too hard, right? So go from deep to superficial. So I don't go vertically because you want to get good purchase. You saw how big that wound was when we started. You want to get good purchase. When I take out these sutures, it doesn't just rip open. So I go obliquely, just in the dermis, don't stitch fat. Deep to superficial. Might have to use my needle holder to help me bring this out because it's pretty deep. You want to mount it straight away where you want it, so don't mount it in the air. Follow the curve rather than just pulling it backwards. Mount it where I want it. Pull the suture along the wound. Leave it slightly longer than normal. Now I'm taking my fingers out because I need to go from this position and rotate in. So we're here and we're rotating in. If you're getting value, like it so other people can see it. Any questions, leave a comment. This will be on replay for our subscribers. Pull it through. 1, 2. This is different to interrupted. You'd lie it parallel, not perpendicular. Parallel. Parallel closes it, perpendicular opens it, like that. If it's loose, let the short end come back that way. So retighten it by pulling the short end. And then it's closed again, and then we can alternate and make it secure. I'm going to do one either side of this, so cut flush. So go on, slide down, angle it, and cut. All being well, I didn't cut my knot. I'm going to do one here, and then we can take out the other sutures and see if it's doing its job. Big bite, deep to superficial. Push it through. Mount it straight away. Put it along the axis of the wound, leave this end slightly longer. Palming it, not going to go in at this angle. I'm going to rotate the needle holder in my fingers. My wrist isn't going to go like this. That's not possible. I'm just going to rotate it in my fingers. And then I'm going to go from superficial to deep in the same angle towards where I started. Just in the skin, not into the fat. Push it down. You don't have to do it all in one. I can see it there, so I'm going to just grab the end. I'm not going to crush the tip. I'm just going to use it to get it out. Put it along the axis. And then we're going to tie. 1, 2. If it's under a bit of tension, or a bit tight, we can do our same finger trick. So index finger goes under. Make a cross, press the cross, go under, pull the suture through, take the tension, and tighten it. I think my previous suture has come out. I cut the knot, guys. I cut the knot. What a disaster. Need to be careful with this one. So we go here. Try not to cut the knot for this one. I guess you get to see me do it again, huh? I cut the knot. Chaos. Okay. I'm gonna focus now. I don't want to have to get another suture out, so I'm going to try and be a bit more economical with my suture material. So I'm not letting the needle get lost deep inside the wound. I'm holding it to keep it up. 1, 2. I'm going to do that. I'm going to tie a few more knots because it's monofilament. Maybe it just unraveled rather than I cut the knot. I didn't feel the bump on the knot. I was cutting it, maybe it's unraveled, so I'm going to make sure it's secure by doing 4 to 6 knots as per the recommendations with a monofilament suture. I can see my knot. I'm going to slide down, angle it, and cut above the knot. Everything's buried, everyone's closed. So just one more, and then we take out these two, and we see how it looks. And then we can talk about how to decide what to put on top of it. Okay, push through, use the tip to get it out so you can get a bit more hold with the forceps. Mount it how you want it, leave a long end, palm it if you need to get the excursion. Remember, I go from deep to superficial on that side, superficial to deep on that side, and rotate. So we're here. 1, 2. And then we're going to take out the other sutures, these locking horizontal mattresses or Summerlad stitches, after doing between 4 and 6 knots. And see if that big gap we had at the beginning is closed. I'm finished with it, so I'm going to secure it. I'm going to park it in a sharps pad. So let's take these out. So ideally you cut at the base of the suture so that this part on top doesn't go back through the wound. Okay, so you can see this gap is really significantly less. So realistically, you put 2 more deep downwards in, one there, and then you have a wound that's closed like this. You could leave it, you could glue it, but you want to really narrow that gap. You've taken off the tension, now you need to close the epidermis, dermis superficially. So you could do a subcuticular, like that. You could do a continuous, or you could just do interrupted. The choice is yours. So the last thing we're going to talk about is our sutures themselves. Skin pad, you can get from our website, is tagged in the products in the description. You can get, it comes with a needle holder like this tungsten carbide one. The last thing to talk about is the sutures themselves. We talked about classifying them: monofilament, braided, dissolvable, non-dissolvable. The additional things you can see on the packet is numbers: 75 centimeters, 3/0. A USP. This is the strength required to break a suture. That strength is this number here, the 3 or the 4, the 5. The lower the number, so the closer to 0, 2010, the bigger the thread in terms of the strength required to snap it. So as you go to 50, 60, 70, 80, 90, 10, 11, 12, the suture becomes microsurgery. So this suture is a microsurgery suture, 80. Tiny suture. How do we know its length? Well, this is the 45 centimeter length of the thread. 45 centimeters, that's not quite true, is it? No, that is not true. Let's use it on a standard. You've got the size of the, here we go. On the packet, if you look here, the needle length is 2.6 millimeters. 2.6 centimeters, 26 millimeters. So it tells you about the needle size. I had that curved shape needle. It was a lot smaller. It was 16 millimeters. So I know that depending on the wound, if it's a small space, 16 millimeters, 1.6 centimeters, is reasonable. If it's a long wound, probably want to work less hard and I use a longer needle, 26. The curvature is described here, 3/8 of a circle. So this is 3/8 of a full circle, so quite a long needle. Whereas this is a compound curve, so you can see how it has a little inflection. As I said, really good for small spaces at depth, such as intraorally. We've got our expiry dates, and there's 12 in a pack. So those are other details that you can look at other than how to classify monofilament, braided, dissolvable, dissolvable. So that completes our suturing course, impromptu. Of course, one of the downsides to doing it live on this venue is that we can't give you direct feedback. So that's why we run our courses on medsyncltd.com/events. And that is limited places, 10 places on each course. And we can do face-to-face, and we can see your kit, and we can give you personal feedback. So if you go to medsyncltd.com/events, we can click the link in the description. We can give you your register, join the course, and we can give you personalized feedback. But if not, we've got all these free videos on our site here. So enjoy, and we'll see you next time. Have a good day.